Perceive, process, perform. Do you need inspiration for your practice, or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration. Dr. Paul Fletcher is a periodontist who lectures on periodontal prosthetics and implant dentistry. In this practice inspiration, he reviews his protocol for in-office and home maintenance of dental implants.
Hi, my name is Paul Fletcher. I'm a periodontist and a member of Specialized Dentistry of New York. And what I'd like to do is present an evidence-based, in-office and at-home treatment regimen for the maintenance of dental implants. Because of the macroanatomy of the dental implant threads and the microanatomy of the dental implant surface, mechanical therapy alone is inadequate to predictably detoxify an implant surface. So, in addition to mechanical therapy, what we're going to use is chemical therapy, with our objectives being to disrupt the bacterial plaque biofilm, detoxify the cell components affecting the growth on the implant surface, reduce bacterial load by dilution to a level that will allow healing. This is disrupt, detoxify, and dilute. These are the basic microbiologic principles that we learned in dental school in our first year, with our goals being to eliminate bleeding upon probing, which is a sign of inflammation, reduce pocketing, and to stabilize bone levels. Now, the key thing we have to remember here is treating mucositis prevents peri-implantitis. Mucositis is a reversible inflammatory reaction in the soft tissues surrounding the dental implant, whereas peri-implantitis is the equivalent of periodontitis, which is inflammation around the surface of the implant and bone loss. So to accomplish these goals, what we're going to do is use a technique called Cumulative Interceptive Supportive Therapy, or CIST, first presented by Langham and Belli back in the late 90s, and then subsequently by Langham and Belli and Berglund. And what we're going to do is we're going to use an incremental approach to treat peri-implant disease. First, we're going to start with treatment A, which you can see here on the slide, which is mechanical therapy. If the disease is more advanced or doesn't respond to what we want to do, we're going to put in treatment B, or antiseptic therapy. If it doesn't respond to what we want to do, we're going to add an antibiotic therapy, treatment C, and then finally surgical therapy. So it's going to be an incremental approach to treatment. So what we're going to use for mechanical therapy is basically a curette. We're all comfortable with curettes. We use them in our office, and we know how to use them. So with pocketing for less than 3 millimeters and absence of plaque and bleeding upon probing, no treatment is necessary. If you have plaque and bleeding upon probing, then we use mechanical debridement and polishing, the curette. With pockets of 4 to 5 millimeters, what we do is we use mechanical therapy treatment A, and we add treatment B, which is antiseptic therapy. Now, what we're going to use for our antiseptic treatment is a dilute solution of sodium hypochlorite, a 0.25% solution of sodium hypochlorite. Sodium hypochlorite is a highly cytotoxic oxidant. There's an 80-fold decrease in biofilm endotoxin compared to water. It's found naturally in macrophages and neutrophils, so you can't be allergic to it and it can't be carcinogenic. There's no visible histological effect on periodontal healing. It doesn't corrode an implant or titanium implant surface because it's basic in nature. And it's accepted as a safe mouthwash by the American Dental Association when used in dilute concentrations. So the question is, how do we mix up a 25% solution of sodium hypochlorite? Well, all you have to do is mix 5 mLs, or 1 teaspoon, of household bleach, which is 5%, 6% sodium hypochlorite, in 4 ounces or 125 milliliters of water. Now, the patient drinking cup that all of us use and all of us have in our dental office happens to hold 5 ounces of liquid. So if you mix 1 teaspoon of bleach and put it into that cup and fill the cup 4/5 with water, you're going to have a 0.25% solution to use. So going back to that, we can try that, and we use that in our regimen in office. And if that doesn't work, we subsequently go to treatment C, which is antibiotic therapy, which can be local or systemic. But we first start with local. And what we're going to suggest or recommend for local antibiotic therapy is minocycline microspheres, or Arrestin. In order for a local antibiotic to be effective, it has to produce at least 100 times the minimum inhibitory concentration for about 7 to 10 days. Minocycline microspheres gives us over 1,000 times the minimum inhibitory concentration for 5 days, and then tapers off and still provides more than 100 times the minimum inhibitory concentration for up to 14 days. The improvements in pocket depth and bleeding upon probing, you see at 6 months, but not 12. But we don't even need it to be effective for 6 months. We're only going to need it to be effective for 6 months. And the improvements in pocket depths are on the average of a range of 1 millimeter. But again, we're dealing with mucositis, so when we go from 5 millimeters to 4 millimeters, that becomes significant, because what happens at 5 and 6 millimeters, the aerobic flora becomes anaerobic and it becomes inflammatory. If we can get the pocketing down to 4 and 3 millimeters, we're in the range where we want to be. So here's the protocol. 3 millimeters and no bleeding upon probing. Gently probe for resistance, evaluate plaque levels, and you prophy cup and polish. With 4 to 5 millimeters and no bleeding upon probing or suppuration, you just mechanically debride with the curette and polish. Now when you have 4 to 5 millimeters with bleeding upon probing, or greater than 5 millimeters with or without bleeding upon probing and suppuration, we do treatment A, which is mechanical therapy with our curette, and we use a soft plastic curette because that's least injurious to the smooth implant collar per se, and it will disrupt the bacterial biofilm so we can get to it with our chemicals. And then we use sodium hypochlorite irrigation with a blunt monojet syringe, and we irrigate subgingivally before, during, and after debridement. After that, what we do is we apply pressure. We apply pressure for 1 minute continuously right at the gingival margin in order to attempt to get epithelial and connective tissue readherence. Epithelium will readhere to any smooth implant surface or any smooth surface. So what we're doing, clean smooth surface. So what we're doing is cleaning the subgingival area of that implant, and it's a smooth surface, and what we're doing is applying pressure to get epithelial readherence. Then we give the patient a home care regimen, and we tell them to go home and brush their teeth and rinse and keep their mouth clean for the next 3 months. Now the home care regimen is really important because controlling the biofilm is critical. And you explain to the patient what we've done is we've cleaned off the subgingival biofilm. The implant surface is clean underneath the gum. Your responsibility now is to stop the supragingival biofilm that's going to be in your mouth from migrating subgingivally and becoming inflammatory. So the objectives are going to be to minimize the subgingival migration of the supragingival biofilm and to keep the subgingival biofilm below an inflammatory threshold. And the way they're going to be doing that is they're going to brush and they're going to rinse. And we're going to ask them to brush their teeth with a triclosan dentifrice. Now in the United States, that's Colgate Total. We have plenty of research that shows Colgate Total will reduce inflammation and leave you with less plaque and gram-negative organisms than any of the other toothpastes around. And that's really well researched. So they're going to brush with Colgate Total toothpaste. The second thing we're going to ask them to do is simply rinse their mouth. We're going to ask them to rinse their mouth with an essential oil mouthwash. Again, in the United States, that happens to be Listerine mouthwash. And there's plenty of research that shows the efficacy of Listerine mouthwash. So optimal home care is imperative. So they're going to brush with triclosan toothpaste twice a day, with one of the brushings right on the implant where the inflammation is, with one of the brushings being right before they go to sleep at night, because salivary flow is reduced when they sleep, and bacteria tend to multiply more at that time. So they brush right before they go to sleep with their second brush, and we're going to ask them to rinse. And we're going to ask them to rinse twice a day with the essential oil mouthwash, the Listerine mouthwash, twice a day. Again, with one of the rinsings being right before they go to sleep at night. And what that's going to do is that's going to remove the bacteria on the tongue, the posterior part of the mouth, and the mucous membranes in the mouth. So what we're trying to do is control the supragingival biofilm and minimize its migration subgingivally. If we can get them to floss, use an end-tuft brush or interproximal brushes, even better, even better. What we also want them to do is around their big frameworks and what have you to use a dilute solution at home of sodium hypochlorite, and you're going to give them a plastic monojet syringe to do. And what they're going to do is mix 1/2 teaspoon of sodium hypochlorite in 16 ounces of water. 1/2 teaspoon of bleach, 16 ounces of water. Draw it up in the syringe and rinse and irrigate under those frameworks 3 times a week. Monday, Wednesday, Friday, Tuesday, Thursday, Saturday. They can pick it. If they have a water pick, and they have a water pick with about a half a 16 ounce or 500 milliliter reservoir, what they can do is put a 1/2 teaspoon of the bleach in the water pick, fill the reservoir with water, and use that also instead 3 times a week on a low setting. Now, what happens is they come back at 3 months. If they still have bleeding upon probing and pocketing, what you wind up doing is you use your local antibiotic therapy. Send them home again. Treatment A, B, and C, incrementally with the irrigation, and then local antibiotics therapy. Send them home again, okay, and tell them to practice and use the regimen. And what we found is we've done research on this regimen, and this was done at Columbia University with my resident Albert Lee and Papapanos, the chairman of the department. And what we did is took 30 patients, 30 implants, 6 sites, measured 6 sites around the implants. And what happened when they used this regimen, the mean circular bleeding index at baseline was 1.39. After just using the irrigation mechanical therapy, it went down to 0.68. And in the cases where we had to use the arrestin and the minocycline microspheres, it went down to 0.23. The probing depths also increased from an average of 4.59 to 3.58 with just the irrigation, down to 3.15 after the microspheres. And the other indices also wound up improving. The bottom line is if you keep your mouth clean, good things happen. So what happens is we see the patient again at 6 months. Patient comes back at 6 months, and they still happen to have bleeding upon probing and what have you. Well, if you take an x-ray at that time. If you see progressive bone loss, you may, and the patient is prone to periodontal disease, you may want to go to periodontal surgery. If you have cement retained restoration, you may want to place the patient on systemic antibiotics in order to get any bacteria out that may be in the soft tissues. And for that, you'll wind up using 250 milligrams of metronidazole 3 times a day for 8 days, and simultaneously 250 milligrams of amoxicillin 3 times a day for 8 days. Hopefully, you'll be able to remove the restoration. If you can remove the restoration, what you're going to do is then remove the restoration and detoxify it, because there's still probably biofilm and bacteria on the underside of the restoration. So once you remove the restoration, you can steam clean it, air polish it, sterilize it. You can detoxify, take a cotton pellet with sodium hypochlorite on it, and burnish the screw axis opening, the platform of the implant, and the underside of the restoration. Then gently curette the pocket lining to remove any inflamed tissue, replace the restoration, and again apply pressure for 1 minute continuously. Send the patient home and evaluate it again and see how things look in 9 months after the fact. So if you take a look at this slide here, you can see this original case that we were looking at. You can see what it looked like originally, and you can see how the bleeding upon probing and the inflammation in the pocket depth has been reduced at 6 months. Now here's another case to look at. This patient really would do anything to keep their mouth clean. But she came in and she had about an 8 or 9 millimeter pocket in the posterior molar area, all right? And you can take a look at the x-ray, and that's the sinus lift that you're looking at there, but you can see there's really been no bone loss around that implant, but there is 8 or 9 millimeter pocketing. So we remove the implant restoration and take a look at what's happening underneath that implant restoration. Look at all the plaque and debris and calculus sitting on that tissue. This is a nightmare waiting to happen. So what we wound up doing is we wound up detoxifying the undersurface of the restoration by burnishing it and using, in this case, an air polisher. You can take a look in the left slide and you can see the reason that we had this 8 millimeter pocket, 9 millimeter pocket. It's all inflamed around that second molar implant, and we gently curette that and debride that. We replace the restoration and we apply pressure. And we apply pressure for 1 minute continuously. And here's the 1-year follow-up. Now at 1 year you can see there's no bleeding upon probing present. Now it still probes 5 to 6 millimeters, but many times you start out with a 5 millimeter or 6 millimeter pocket in the maxillary tuberosity or in the maxillary molar area. So you're actually starting with a pocket. The idea is, and the important thing, it doesn't bleed. And during the patient's recalls, we again just keep irrigating and keep maintaining the implant situation. Final case. So if we take a look at this framework here, this is impossible for a patient to keep clean. We all have patients like this. We all have cases like this. A patient can't get under to keep it clean. We took off the restoration and we took a look. The patient had a soft tissue abscess on that distal implant, and you can see how inflamed it is, and you can see how the other implants are also inflamed. We took off the framework, we detoxified it with a cotton pellet soaked in sodium hypochlorite. We went into the threads in the top part of the implant access opening, and we also burnished that and detoxified it also. You clean everything you can clean. We relieved the framework of the restoration, and we replaced it. We had the patient use the irrigation from the water pick, getting underneath there with the sodium hypochlorite. 3 months later, we have to remove the framework for a prosthetic repair. And if you take a look at what the tissue looks like under there, the tissue is healed. This is an entirely different appearance than what the tissue looked like originally. Now, when I speak about this, I say this isn't magic. This is just a matter of the patient keeping the mouth clean and removing and eliminating the bacteria. So this is the protocol. Feel free to use it. I think you'll see a significant difference, and you'll reduce your number of incidences of mucositis changing to peri-implantitis. I hope you found this presentation informative, and I'd like to thank you for your time.